All right, let's see how this is working. All right.
All right, we're going live.
Okay. I think someone gave a thumbs up. So now there's someone saying no, they can't hear us.
Oh yeah. Yeah, I'm live.
Okay, they can't hear me. Let me see. Can you guys?
Can everyone hear me?
They can hear you. I think they can hear you, Mike. But can anyone hear me? I wonder if okay. Can you hear? They said they can hear you, Mike, but okay, they hear me. Okay. Okay, let me there's a delay.
All right, okay, so some of them are saying they can hear both of us, but then some people say they can't hear me.
Okay, Mike, mute what you're seeing on YouTube and just go run it on eCam. Sorry, guys. Hey, can you guys hear me?
All right, so
Let's see, I can hear only Dr. Hansen.
oh, okay. All right, what about? Can you hear me now? All right, if you can. Okay, if you hear me, type in Mike in the comments below. All good now. It says all good. Okay, it says all good. Type in Dr. Yo. Okay, we're good. We're good. Maybe do you want to send them just to my channel then? They're from my channel. They can say they can hear me. Okay. All right. So I think we get started now. Okay. Rom, now they're saying that your levels just got low. So try doing this, Rom. Try muting your Skype and then unmute your built-in microphone or your headphones. Maybe it's your headphones. Maybe that's why I got low. Maybe they can hear you now with the headphones. Yeah. Try both ways. See what happens. Only they only hear me. So they can only hear me, so now do the opposite. Okay, so try the headphones. Try taking out the headphones and try both built-in mic and the Skype, or one or the other. Okay, they're saying they can hear you now. Okay. Sorry guys, this is our first time doing this. Oh, they can't hear you. All right, maybe you're muted. I'm so confused right now. Can you hear Rom now? All right, Rom, do you want to try this? Maybe you can do. You want to end the Skype and then do a FaceTime me, and then we can do it that way. Okay. All right. So here's what we're gonna do. Rom's gonna hang up. He's gonna FaceTime me, and then we'll do this together through my FaceTime, and then we'll just go and start addressing this. All right. Why don't you just hang up and then give me a FaceTime call, and then we'll go from there. Yeah. All right. So I don't know. Some people say that they can hear, others say they can't. So we'll just go ahead and get started. Okay. All right. So hello everyone, and can you all hear me now? Only Mike. Yes. Okay. You guys are very busy. Glenn Rogers. Hold on. I'm on the phone with it. Call you on. No pressure. Take your time. Are these doctors? All right. So I have Dr. Yo on the FaceTime with me now. So here he is. We're together, so we're going to go ahead and get started. All right, so who is up for the first question? Let's see. First of all, I want to say, before we get started, I want to say thank you all for joining us. This is our first time. Sorry for the technical difficulties, but we've wasted enough time, so we'll go ahead and get started now. Don't either of us own a razor? Yeah.
I'm looking for the barber shop to open. My hair hasn't been this long in years.
Well, you know something? I actually tried cutting my hair today. I kind of botched it, but it's doable. I'm able to get by. Okay. All right. Like the video, guys. We have a crazy issue in the UK about herd immunity, says Rachel Kingsley. All right, so what is it about the herd immunity? Okay, Ivermectin. Lex Weaver has a question about Ivermectin. So, Ivermectin is it's a drug that they did a pre-peer-reviewed study on in vitro on ivermectin, and basically they showed that given one dose of ivermectin with the virus in vitro, it reduced the levels by 5,000-fold within a 48-hour time span. And the way that it's thought to work is that it inhibits some of the proteins of the coronavirus from going from the cell into the nucleus, and that's why it's thought to be effective. But there aren't any clinical trials in humans, so we can't say for sure if it's going to work for COVID-19 in humans.
If there's can you hear me, Mike?
Yeah, I can hear you.
Okay, can everyone hear me on YouTube? Not seeing anything, Mike.
All right, can you hear Ram, Dr. Yo? All right, risk factors for folks with asthma. All right, so asthma is an inflammatory condition. And, you know, someone with asthma myself, it's something that I'm very aware of. And, you know, being a pulmonologist, I treat a lot of patients with asthma. So the thing with asthma is it's an inflammatory condition, meaning the airways of the lungs have swelling. Not all the time. Some people only have swelling sometimes, and then other people have worse asthma and they have more swelling than other people. So when you have this swelling going on with uncontrolled asthma, then that's going to make you more susceptible to respiratory viruses such as SARS coronavirus 2 because of COVID-19. So, you know, even though there aren't any studies that are looking at specifically people with asthma, in theory, these people are at higher risk of getting it and having worse outcomes with it, especially if it's not controlled. And the same thing would apply to smokers because the smoking also causes inflammation within the airways of the lungs. Now, Ram, Dr. Yo's here, and I saw one question that had to do with ARDS and inflammation.
Yeah, there have been a couple of questions here about cytokine storm. So it's really, really interesting. So what the cytokine storm is, cytokines are basically these messenger enzymes. So the way I like to look at cytokine is, okay, good. I'm glad you guys are hearing me. Okay, so with the cytokines, just think of them like the military. So you have the Army, you have the Navy, you have the Air Force, you have the Marines, you have the Coast Guard. And how they communicate with each other is the key. And that's what basically cytokines are. They're almost like, they have so many different roles. One of them is they're messengers. Some of them, they're pro-inflammatory, they're anti-inflammatory. So that's really what cytokines are. And they're produced by so many different cells. So for example, you have these stem cells, and stem cells are found in the bone marrow, usually of the femur, of the long bones, the femur, the sternum. And that's why when you're doing biopsies, they'll take bone marrow from the femur, for example. So there are two different types of sort of lineages. One is a myeloid and other is a lymphoid. And I'm not going to get too much into details. I'm actually doing a video on this that I'm posting in about 2 days, where the lymphoid are going to be making the T cells and the B cells. Your myeloid progenitors are making platelets or the precursors to platelets. Your monocytes, your macrophages, your neutrophils, your basophils, and all of them make cytokines. And what the cytokine storm is, what that means is basically it's an overactive and overstimulated immune response. So think about it. Like I said, you think about the different branches of the military, and they are just sort of talking to each other. And if the messages sort of get confusing or one misses the message, they're not in sync. You got to think of the immune system like it's almost like a symphony when everyone knows their part. You got your percussion, you got your strings, you got your pianos, and when something goes off, or if a message is going off, then what happens is you have this situation called the cytokine storm, where one group suddenly gets the wrong message, or they don't get the message, and they start attacking your own body cells. And that's the sort of a quick overview of what the cytokine storm is. Now, there's some research that suggests, and I know there's a research out in Australia that came out in 2015. And so you got to keep in mind, all of this cytokine storm has been studied from the first coronavirus from 2003, I believe. So the study from Australia, and like I said, I'm going to go really in depth into a video on this in about 2 days. So, guys, just, I'll really get into the nuts and bolts of it then. But this study showed that there might be a genetic mutation with some people that makes them more susceptible to a cytokine storm. See, what happens is, when you have a normal cell and you have the virus attacks that cell, it goes inside that cell, so the body's immune system cannot recognize that the cell is infected. This is just one of the ways that the virus tries to hide from your body's immune system. So what happens is then your own body cell then takes a piece of the viral protein, and it will stick it on top of itself. It's kind of like almost like a flag. Like, think about it. If you're on a deserted island and you're trying to get a signal out that you're in distress, so you're sticking almost like this flag, and that flag is a viral protein telling the rest of your immune system, hey, I'm infected. There's something going on here. So what then your T cells will come in and they bind to those viral proteins, and it's something called MHC, major histocompatibility type 1 is the name of how it's displayed on your body's own infected cell. And what happens is then the T cells then will come in and attack it. Now, one of the things that the T cell uses is there is a protease or an enzyme that called a perforin, that what it does, it does what the name sounds. It perforates your body's infected cell, and then it releases an enzyme called the granzyme B into the infected cell and kills it. And then B cells come in and they make antibodies. So there's some studies that show that there is a genetic predisposition or some genetic mutation that causes some people to where the perforin that they're making is it's ineffective, and it could be a low amount or it could be a defect in that perforin. And what it does, it further stimulates the cytokines because it's not getting that signal. It's almost like the signal is coming through, but there's a wall and it's not getting through. So it just keeps on sending more of that signal. And that is one potential etiology behind the cytokine storm.
Yep, and I'm seeing a lot of questions about genetic susceptibility and ACE2 receptor, as well as why men more than women. All right, so I'm actually going to make a video on this coming up probably in the next 2 days or so, but what I want to talk about is there does seem to be genetic susceptibility in terms of why some people who get the virus do okay, and then why others don't do so well. So what we know is, as far as how the virus attacks, this virus has a spike glycoprotein, and that acts as the key to getting into our cells. Specifically, it binds to the ACE2 receptor. Now, these ACE2 receptors are in multiple spots in our bodies, but when it comes to our lungs, they're in our alveolar type 2 cells. So when they get down inside our lungs, down into the alveoli, this glycoprotein attaches to the ACE2 receptor. And what we know is that the ACE2 receptor gets down-regulated, meaning there's less of it on the cell. And what happens is, as a result of this, is there's less angiotensin 2 conversion into angiotensin 1-7. Now what this means is, because there's less of angiotensin 1-7, this triggers inflammatory responses within the lungs. And this actually triggers the cytokine storm. It's an activation pathway, and there's a cascade that ensues after that. Now, why some people get this, where they have this bad inflammatory reaction with ARDS, and why some others don't, there's actually genetic polymorphisms, meaning there's different variations on these proteins that I'm talking about. So while some might have one variation, another person has a different variation, and this is playing a role in terms of why some people get it bad and why other people don't get it bad, and probably the same reason for why men get it worse compared to women. Now, before COVID-19 came out, we already knew with ARDS that men have worse outcomes compared to women when it comes to ARDS. We also know with ARDS, before this COVID came out, that diabetic patients actually didn't do as bad compared to non-diabetic patients. Again, this is ARDS in general, not specific to COVID. And then we also know that smoking and also being older tends to have a worse prognosis with ARDS. So these are all factors that are associated, correlated with worse outcomes, but we don't know exactly the exact chemicals involved in the whole process. Pim, okay, your thoughts on using masks to stop transmission in the community. Ram, you want to take this one?
Yeah, absolutely. So this has been, the mask question has been sort of confusing. Now, initially, it was the CDC came out with guidelines saying that the masks were only for if you're exposed to high-risk situations, like you're in the hospital setting, you didn't have to wear it in the general public. Now, there's some countries that have been wearing masks way before. I know the Czech Republic, there's been this video that's been floating around about how the Czech Republic mandated everyone wearing masks. I think Austria, about a week ago, passed a law saying everyone going into the supermarket is required by law to wear a mask. And so the question is, why is there a shift in it? And I think part of it is there might be some studies that are showing that it potentially might be aerosolized. And what aerosolized means, and again, I posted a video on this on my channel. is that the droplets usually can last, like if it's respiratory droplets, it's heavy, and it usually goes around 6 feet of someone. Whereas if it's aerosolized, it can actually travel a little bit longer. Now, the evidence is not very conclusive. I think there's a couple of theories about that. But I feel like the issue of social distancing and the respiratory droplets sort of became more serious. I think people started to realize how infectious this was. And that's why I think some of the changes were made to the recommendations. It is very frustrating because I think in some of the earlier videos that Dr. Hansen and I were making, we were relaying some of that information about wearing masks. But of course, they've changed it, the recommendations, and I feel like the CDC was sort of a little bit behind. Not to be too critical of our health organizations, but they were a little bit behind some of our other colleagues and other countries.
Yeah, so just to kind of, I see some of the questions about masks and about airborne. So most of the transmission happens through respiratory droplets and contact as well, but it can be airborne as well. It's just a very small percentage of how this virus is transmitted. Think of it like if you get into an elevator with a bunch of people and someone sneezes and let's say they don't cover their mouth. Sometimes you can see that little spray, those fine particles floating in the air. Well, that's when you could have that virus linger in the air for a little bit. When they looked at studies in terms of how long it can stay aerosolized, it's for up to 3 hours. But just because that study showed that it can be up to 3 hours, it's not proven that actually, they haven't shown anyway that it can actually go from airborne, lingering in the air into other people. But just because they haven't proven that yet doesn't mean it doesn't happen. So basically, based on what we know about how long the virus is in the air, this is a form of transmission, but it's less common compared to the other ways. So again, think of it most likely to occur as if you're in an elevator with a bunch of people and then you inhale that pretty much right away. As opposed to going outside and there's no one around you, then you're not going to get it that way.
And Mike, I'll just follow up on what you said. You're absolutely right. That study that came out that looked at the potential of aerosolization of COVID-19, that was done under very strict lab conditions, and they used this jet propeller that is much more powerful than a human cough. So just have to take that into consideration from that study that came in looking at respiratory or being aerosolized.
Yeah, and then someone was asking about, can you eat it and get into your intestines? And the answer is, we know that the ACE2 receptor exists in our intestines. So it is plausible, and we also know that we found PCR in our stool, not mine, but but it's been shown in the stool, PCR. So it is plausible that this virus can be eaten and then it attaches to the ACE2 receptor in the intestines. And some patients have had nausea, vomiting, diarrhea as manifestation. So although I think it does happen, I don't think that's the main issue, but definitely part of the issue as to what's going on. And then someone was asking about seasonal allergies and are they at increased risk because of seasonal allergies? And so I'll say this, kind of like similar to asthma. First of all, seasonal allergies, we're talking about allergic rhinitis, which has a very high overlap with asthma. Most patients have, if they have one, most patients have the other. And with seasonal allergies, or just perennial allergies, what happens is you have, if it's uncontrolled, you're going to have inflammation within your airways, including in your nose, and it can also be into the back of your throat. And if they have asthma, it could also be down into the airways as well. So if the inflammation is not controlled, meaning if you don't have your allergies controlled and there's inflammation there, there's going to be a higher risk that you can get the virus. And then someone was asking about Losartan. So Losartan is an angiotensin receptor blocker, and it is actually being studied right now. It's in a clinical trial. So if you remember me talking before about this ACE2 receptor and how it gets downregulated, meaning there's lower amounts of it, well, when that's downregulated, it's going to lead to more angiotensin 2 buildup around the cells in the lungs. And when this angiotensin 2 builds up, that's going to lead to more potential to bind to the angiotensin type 1 receptor. And Losartan inhibits that process. I'll show you a diagram of what I'm talking about here. Actually, I don't know how to share my screen. Well, anyway. Where'd I go? So anyway, the Losartan is in a clinical trial, and what it does is it inhibits the binding of angiotensin 2 to that receptor of angiotensin type 1 receptor. And the thought process is if you block that from happening with that medication, you're going to have less binding there, which in theory will lead to less angiotensin 2 causing disruption, causing more inflammation within the lungs. So if you have that blockade in place there, you'll have, in theory, less inflammation within the lungs and less ARDS.
Someone has a question about, do patients put to sleep when they are put on a ventilator? I think I don't have one. I believe you are referring to if they are under anesthesia.
Yeah, so Dr. Yo is an anesthesiologist. He intubates, means puts a breathing tube in patients in the OR for the most part. And when I do that, when I put the breathing tube in people and have them on a ventilator, that's in the intensive care unit. Both of us give sedation so that the patient is knocked out, essentially. They lose consciousness so that when we put the breathing tube in, they're comfortable for that process. Dr. Yo, you have any thoughts on that?
Yeah, absolutely. I think it's the ventilator that Dr. Hansen would use in the ICU. It's a little bit different than the anesthesia ventilators. The principles are the same. He will have more control over some of the. I think the ICU ventilators have a little different settings than what I have in my anesthesia machine. The anesthesia machines I have the anesthetic gases, sevoflurane, desflurane, that they're basically called vaporizers. So they're configured a little bit different, but they could be used in an ICU setting if that was your question. I think some of the operating rooms have shut down their elective surgeries, so those anesthesia machines are being converted into using ICU from an ICU perspective. And yes, when you are under general anesthesia, a lot of times you are getting intubated. You don't realize that because you are going to sleep. People think that anesthesia is just taking a nap. It's actually a medically induced coma, and we put a breathing tube in afterwards.
Okay, so got some questions about antibody testing. Well, here's the thing. Right now, all the tests are done by PCR testing. So PCR testing is taking the virus messenger RNA, and then with the PCR, we're basically amplifying that and matching it. The problem is that the sensitivity of the tests aren't that great, meaning the accuracy. So when we do a swab, we swab someone's nose and we swab the back of the throat. The problem is that lots of times these tests don't come back negative. Don't come back positive even though we think the patient still has it. There are reports out there that it has a 30% false negative rate, meaning of all the patients who have it, who we test, only 70% of them actually test positive for it. So that's a problem with this current PCR testing. Now, with the antibody testing that recently has been approved but is not being utilized because it's just not available yet, at least for most places, this testing, we're looking at the antibodies to the virus in the blood. So what we do is we get blood work and then we are measuring the IgG antibody and the IgM antibody. The only thing with that is the IgM antibodies don't start to form in the blood up until about 6 or 7 days or so. So there's going to be a time lag between when they first get infected and when those antibodies, the IgM antibodies, will show up in the blood. So that's the only downside to doing this with the serum. But the good news is that with the IgG that we're testing in these serum antibodies, someone could have that infection like 3 months prior and it'll still show up positive 3-4 months later with the IgG. So we'll know if they're infected or not. And the other plus about doing this is that you have the potential to know if they're infected before. Let's just say we could tell that someone was infected 3 months ago, then we know that they have the potential to have these antibodies that could be used to give to someone else who has a severe infection with COVID-19. So what we could do is have them, we would draw blood from those recovered patients who've had the virus, and then we take that blood and then we spin it down, and then we put that into what we call fresh frozen plasma, and then we transfuse someone else who has severe infection. Okay. Let's see. All right, now someone was asking about ECMO. You want to take this one, Dr. Yo?
I think someone had a question about ECMO in China. That was a question on my Facebook wall. So, you have any idea about ECMO in other countries, or I mean, you're dealing with it more in the ICU than I am.
Yeah. So the thing with ECMO, ECMO stands for extracorporeal membrane oxygenation, and what that is we take blood out of the body and then we put oxygen into that blood and remove carbon dioxide from that blood, essentially taking over the function of the lungs. And then once we do that, we return that blood back to the body. The thing with doing this is it's a very risky and dangerous procedure because you have to have huge catheters that go in, typically to the neck here and into the groin. And these huge catheters, there's going to be clot that forms on them. So that's why we have to give blood thinners to prevent those clots. So ECMO has about a 30% chance of bleeding. There's also other risk factors or other adverse effects that can occur from the ECMO. The other thing is there's only 250 hospitals in this country that have ECMO. So if you go to a hospital that doesn't have it and you need it, you would have to be transported to another hospital just to get the ECMO. And lots of the hospitals in this country do not want to take a transfer of a COVID-19 patient. It's just the reality that we're in right now. So to answer your question, ECMO, it is a possibility. There was a recent study that looked at severe COVID-19 patients who they're basically failing the ventilator. The ventilator wasn't good enough for them and they're dying. And they did ECMO on 6 patients. And that's in this study. And only 5 of them survived. So that gives you an idea that it's, it can be done, but it doesn't happen very often. And when it does, it's definitely not a guarantee that someone's going to live.
Mike, what are the typical? Do you know off the top of your head what the mortality rate is with someone on ECMO? I would imagine it would be much higher than mechanical ventilation.
Yeah, I mean, there's only one study that I'm aware of that looked at ECMO for COVID-19 patients, and there's 6 patients in the study, and only 1 survived.
So, someone asked, what drugs have been effective for you in treating COVID-19 patients in the ICU? You want to tackle that, Mike?
So there's really no specific drugs. It all depends on. So with all these different clinical trials that are going on, the way that it works is these medicines enter clinical trials, and then some hospitals are giving them while other hospitals aren't. These drugs are typically given at academic centers. So we're talking about university hospitals. And what they do is, for the drugs that are in randomized clinical controlled trials, they say, listen, we're going to give you a drug, and it's in the clinical trial, and it's either going to be a placebo or the real drug, but the patient doesn't know which one they're getting. And then they analyze the results later on, and that's where all these drugs are at right now, are in these clinical trials. So this includes things like remdesivir, Kaletra, which is a drug for HIV. It also includes Losartan, hydroxychloroquine, chloroquine, I think in combination with azithromycin, and then Ivermectin has not entered clinical trials. And there's another one called tocilizumab, which is an antibody that reacts against the IL-6 pathway. So that's also in clinical trials, and that's also shown some promise, at least in a few cases. So basically the answer is we don't know definitively if these drugs, or if any of these drugs will work or not, but we're still waiting anxiously for the results of these clinical trials.
Yeah, I agree, Mike. And I would say, sort of the big thing is hydroxychloroquine, which I'm starting to realize is a very controversial topic to bring up. But I just want to address it where, now I'm speaking very anecdotally. I have three physician friends of mine that are currently intubated with COVID-19 around the country. And all three of them are not responding to hydroxychloroquine. Now, I'm not saying it is not effective, but for every study that says that it is effective, and there is another study that comes out very strongly and says there is no effect. So, like Dr. Hansen was saying, there isn't one specific treatment or therapy. We're not exactly sure when to start hydroxychloroquine. Do we start it in the middle of the disease prognosis, or towards the end? A lot of my friends that were on the ventilators, they got hydroxychloroquine towards the end. Could they had a better outcome or responded better if it was done early? That is something that we don't know, and that's why the clinical trials need to be done. And I know there's a lot of people who had posted on my wall, and they're sharing with me their frustration. We all want, and trust me, Dr. Hansen and I, we are affected by this. We're in the front lines every day. So we definitely want something. We want some treatment. A lot of our friends are sick, and some of them are gravely ill. So the thing is, we don't really know, and we're really throwing something against the wall and hoping it sticks. That's really what it is right now, which it's also a little bit scary as physicians, because information and new studies are coming out. So we're trying to be super cautious in what we're telling everyone.
Yep. And someone was asking about steroids and also heparin prophylactically. So, with steroids, the recommendation right now is you don't give steroids to a COVID patient unless you're going to give it for another reason. For example, lots of times when patients have COPD exacerbations that land them in the hospital, those are times we give steroids. So if that patient were to get COVID-19, we would give steroids to that patient. The other recommendation is if someone has severe ARDS, we did this before COVID-19, if someone had severe ARDS, we would give steroids. And so that recommendation stays the same if someone has COVID-19 along with steroids. But otherwise, the recommendation is not to give steroids. Now, if any of you have seen my video on the autopsy report analysis, in that video, that patient ended up getting steroids. He died, but again, that's one patient, so you can't really make a judgment based off that. The other thing is, I've had a patient who, I swear up and down, had COVID-19, but I think it was a false negative test. Regardless, she ended up getting steroids, and she got better. So, was it COVID-19? Not sure. Could have been, but she did get steroids, and she got better. Now, someone was asking about giving heparin prophylactically. That's a good question, because for ARDS, before COVID-19 was a thing, we know that in ARDS, there's microthrombi, meaning small, tiny little clots that form within the lungs. And so the idea was that if they're having these tiny little clots within the microscopic blood vessels, the capillaries of the lungs, well, why don't we give heparin for that? And will that improve the ARDS? So actually, they did try that, and it caused a lot of bleeding, and patients actually had worse outcomes with the heparin. So we don't give heparin in terms of the big doses to treat COVID-19 ARDS prophylactically. We give prophylactic heparin in the small doses, like 5,000 BI twice a day or 5,000 3 times a day, but that's prophylactically just like we give anyone else heparin. So we're not making the blood thin just based on presumptively treating ARDS. I know some people, I think some doctors are, or they're considering that, but that's not the recommendation, and they could actually have worse outcomes with that. All right. So someone was asking about viral load and the dose of virus. So I do think that's a part of it. We don't have studies that show this definitively, but I do think a part of it is related to how much of that virus gets into your lungs, specifically the alveolar cells that I was mentioning earlier. So I do think there's a genetic predisposition for the ones who do worse, but I also think it's related to the viral load. But I can't say 100% sure because we don't have studies showing that. But you would think based on the healthcare workers having the more exposure and the number of healthcare workers getting it, I think it would be reasonable to assume that's the case. What do you think, Dr. Yo?
Can you repeat the question? I was responding to
inhaling more of a viral load or getting more of a viral load into your lungs, does that make it a worse outcome?
Well, I think most of the studies have shown that the viral, so the amount of viruses that you are exposed to has an increased risk of contracting disease. And one of the words you hear is fomite, and that means the surface. And so if you come in contact with a low dose or a low amount of viral particles, then you have a less risk versus someone that is coming into contact or exposure with a high viral load. And we all know that from all the studies and the evidence that this is still a respiratory illness. The infection comes in through your mouth, your nose, your eyes, and it travels down your respiratory tract, your mouth, your oropharynx, and then eventually all the way down to your alveoli. So your amount of exposure to the viral particles is really key. And you're seeing a lot of, on autopsy and biopsy reports, as Dr. Hansen and I earlier we were talking about, you're seeing most of the viral particles in the lung tissue.
Yeah, and someone was asking about pneumonia vaccine, and does the pneumonia vaccine have any impact? And I think that's a two-part question. One, does the pneumonia vaccine prevent you from getting ARDS or pneumonia? And then the other thing is, does the secondary bacterial infection pneumonia after the viral syndrome, just like what happens with influenza when you get a secondary bacterial pneumonia? The answer is no. So the pneumonia vaccination is to help prevent or reduce the severity of pneumococcal pneumonia, meaning pneumonia that's due to a certain bacteria, Streptococcus pneumonia. So that bacteria is the one that's causing a certain bacterial pneumonia. There's thousands of different types of bacterial pneumonias and different viral pneumonias. So the one bacterial pneumonia that tends to happen after viral infection, especially what we know with influenza infection, that's pneumonia that's due to Staphylococcus. So Staphylococcus aureus pneumonia. So the pneumococcal vaccination will not help you in any way against COVID-19. Okay, and then another question was, why did Boris do so well? Well, we don't know exactly why he did so well. There typically seems to be three types of pathways of when someone gets sick with COVID-19. I'm not talking about the people who don't have symptoms. I'm not talking about the people who have mild symptoms. I'm talking about the people who end up getting fairly sick. And really, it's going to be one of three pathways. One, they feel a little ill with a fever, maybe dry cough, but they don't necessarily have pneumonia. They don't necessarily have to go to the hospital. That's one. The other one is someone who has all that, plus they have pneumonia on the x-ray and their oxygen levels come down, but they do okay. And I think that's the category that Boris falls into, as well as the patient that I was talking about earlier, who I swear up and down had COVID. And then the third pathway is when someone gets super sick, where they have full-blown ARDS, where they require a mechanical ventilator, and they have the possibility, a real possibility of dying. So I think it's one of those three pathways that's typically the way this COVID-19 is playing out.
So someone asked a question about what if you get flu and coronavirus at the same time as the flu? So this is a very interesting question. There is some people talking about how this coronavirus has been in the news recently. How coronavirus didn't really get into the United States, or at least in the Western European countries. I think their understanding was it hit China in the end of December, and then came around to the Europe the end of January, early February, and the United States in the beginning of March. It sort of is the rough timeline. And there are some people saying that some of the symptoms they were experiencing were like coronavirus, but they were experiencing back in October and November, and which makes us, they were initially told that they had flu and influenza. So the question is, can you have both coronavirus and influenza? Absolutely. And that's because they are two very different viruses. One of the questions I get asked a lot is, can you treat a coronavirus patient with Tamiflu, the antiviral? And the answer is no, because those were designed purely for influenza virus. Some of the earlier studies out of China, they were treating their patients with Tamiflu, and we now know it's not effective because it's working on the influenza antigen. And so you can actually have both type of infections concurrently at the same time, which is just bad luck, I guess.
Yeah, and then someone was asking about LAM. Wow, that's incredibly rare disorder. Sorry you have to experience that. So LAM stands for lymphangioMyelomatosis. It's been so long, I'm sorry. Maybe you could spell it out in the comments. It's incredibly rare disorder. Typically, might be only young women. Pretty sure it's only young women who get that. But it's incredibly rare. And there's often cysts that develop. And her question was, with pneumothorax, because these patients get pneumothorax, what about high PEEP on the ventilator? Well, I think hopefully you never get this virus, so this doesn't become an issue. But the question about high PEEP on the ventilator, yeah, the higher the PEEP is on the ventilator, the more likely you are to have pneumothorax, which is where the lung collapses, a flat tire, if you will. And so, of course, in general, we want to avoid too much PEEP, but especially in someone with LAM who's at risk of pneumothorax.
That was someone just asked a question about hemoglobin. So we'll you wanna jump in on that question?
All right. So yeah, someone is talking about that the virus, the SARS coronavirus 2, is inhibiting the hemoglobin, specifically the beta-1 chain of the hemoglobin molecule, displacing the furin from the porphyrin ring. Now, this is based on a non-peer-reviewed study that came out of China. And based on this study, they said that it could. They didn't say that it definitively did do this, but they said that it could, that the virus could somehow inhibit this part of the beta-1 of the hemoglobin. Now, there are several reasons why, even if this did take place, it's not what's causing the pathophysiology. It's not what's causing the disease. I'm not saying that it doesn't somehow impact the hemoglobin in vitro in the test tube, but that's not what's causing disease with COVID-19. We know this because for several reasons. One, the pathophysiology of COVID-19, we know that it uses the ACE2 receptor in the pulmonary alveolar cells. And based on that, we see the ARDS and not only the ARDS findings on the pathology of autopsy, but we also see the viral cytopathic changes on the histopathology based on those biopsies from those autopsies. So that's one thing. The other thing is, if that were the cause of low oxygen saturation, then you would not have a low PO2 to FiO2 ratio. So the PO2 to FiO2 ratio is when you have the oxygen that you inhale versus the amount of oxygen, the partial pressure of oxygen in your blood. So normally there's not much of a gradient there, but when someone has lung disease where it's impairing the flow, the diffusion of oxygen past the alveolar capillary membrane, if there's a blockage there, you're going to have lower partial pressures of oxygen in the bloodstream. If it were just a case of attacking the hemoglobin as the cause of this pathology, then you would expect to see a normal PO2, and that's not the case with these patients with COVID-19. The other thing is, if you look at methemoglobinemia, I don't know if anyone knows about methemoglobinemia, but that's a disorder of the hemoglobin molecule where it's not these portions of the porphyrin ring, the iron there, is not able to bind oxygen. And what happens with these patients is the percentage of their hemoglobin that's normal goes down, further down and down. And that's what's causing the desaturation. The percentage of hemoglobin becomes desaturated with oxygen. So that's what's going on with methemoglobinemia. So with methemoglobinemia, you don't have reduced PO2 levels in the blood. You don't have reduced partial pressure of oxygen levels. The other thing that kind of disputes that theory would be the fact that you don't see any ACE2 receptors on the red blood cells. We know for a fact that ACE2 receptors are not on red blood cells, so that's not allowing the virus to get into the red blood cells. The other thing is with the hemoglobin, if the virus were to somehow break open that red blood cell, not just saying get into it, but somehow break it apart, and then somehow get to the hemoglobin after the red blood cell breaks apart, well, we don't see any of these patients having hemolysis. We don't see any results. We don't see any evidence of hemolysis in these COVID-19 patients. So this idea that the attack of hemoglobin as a cause of COVID-19 is disproven.
Yeah, I just posted a video on this topic a couple of days ago. So if you guys haven't subscribed to my channel, it's Dr. Yo. So you can see this video that I posted on hemoglobin. And one of the things was I suggested that if hemoglobin, or let me take a step back, that there might be some other underlying etiology taking place. I think Dr. Hansen and I think we agree that this is a respiratory virus, and we cannot downplay that. But there might be a potential that there might be a different sort of etiology taking place secondary to a respiratory route. Now, the thing with hemoglobin, and there is a big question about does it play a role? Maybe, maybe not. I mean, as Dr. Hansen just said, there's a lot of evidence that suggests that it doesn't. You know, looking at your PF ratios, and you're looking at your partial pressure of the oxygen. But the mechanism of action of hydroxychloroquine in malaria is that the Plasmodium, which is the parasite in malaria, has something called a food vacuole. And the food vacuole actually is a structure, it's an organelle inside the Plasmodium. And what it does is, how hydroxychloroquine works is the food vacuole breaks down hemoglobin to heme and globin. And the heme actually that it breaks down is actually toxic to the Plasmodium. So what the Plasmodium does, it actually makes a chemical to protect itself from the heme. And how hydroxychloroquine works is it increases the pH inside the food vacuole, and then it blocks this chemical that the Plasmodium is making, so that heme actually will cause the destruction of the Plasmodium. Now, one of the things I tried to illustrate is we are using hydroxychloroquine to treat COVID-19. And sort of the accepted theory is that hydroxychloroquine works potentially on the spike protein and also works on the ACE2 receptor. Now, another theory is that when the virus enters the human cell, enters one of your cells, there's a process called endocytosis where it takes a piece of the sort of, I make an analogy in my video where it's like you're taking a piece of someone's skin and you're wrapping yourself around it. And it gets inside your cell and it calls itself a viral endosome. And those viral endosomes are actually acidic in nature, just like the food vacuole in malaria. Now, it is believed that hydroxychloroquine actually increases the pH inside this viral endosome, thus inactivating the viral proteins, and then the virus cannot replicate. So could there be some sort of correlation between how the mechanism of action when malaria versus COVID-19? We're not sure. Now, the other point I think Dr. Hansen touched upon, and I agree, is we don't know if the virus actually invades the red blood cell. Red blood cells do not have a nucleus, so viruses don't like attacking red blood cells because they need the machinery of a nucleus in a cell because they basically come and they hijack. It's like, think about you have a factory with all these machines in it, and someone comes in and use it to make their own equipment, and that's pretty much what the virus is doing. So if you don't have the equipment, then you have no interest in it. And that's pretty much the relationship between viruses and red blood cells. So there was a study out in China that actually looked at it. Again, they were not clinical trials. They looked at it in a lab where they isolated 2 glycoproteins on COVID-19 that were attacking the porphyrin ring of hemoglobin. And they suggested, this is not saying that this is the only route and it's not respiratory nature, but they suggested that there might be some involvement with hemoglobin in the pathogenesis.
All right, another question. This is a very good question because it's a very big issue with a lot of people. So should I still take my ARB or ACE inhibitor? So my ARB in terms of angiotensin receptor blocker, that's like Losartan, Telmisartan, or an ACE inhibitor like lisinopril. So, or ramipril. So there's actually a big article that talked about this in New England Journal of Medicine just within the last week. And the recommendation is, yes, absolutely continue to take these because even if you don't get COVID-19, let's say you don't get COVID-19 and you stop taking these medications, the effects that they have on your cardiovascular system, whether that's CHF, whether that's hypertension, whether that's worsening kidney disease, absolutely continue to take these medications. And then, of course, there's always things related to that, like with hypertension, increased risk of stroke, and those sorts of things. So yes, continue those medications. And then the other thing is, how much do the ARBs, ACE inhibitors, impact your chances of getting COVID? Or if you do get COVID, how much does it impact the severity of the COVID illness? So that's something I talked about earlier in this session here, but it's not known exactly if they will be beneficial. Like I said earlier, Losartan is in the clinical trial. And in theory, my gut feeling on this that I feel pretty strong about is that these angiotensin receptor blockers, more so than the ACE inhibitors, I think Losartan, Telmisartan, these types of medications are going to have a big impact on the severity of illness. But again, we have to see what the clinical trials are going to show. I'm going to make a detailed video on this, actually 2 videos on this coming up. So definitely check out my channel for those next videos. All right, so a lot of questions too on high dose vitamin C. Dr. Yo, do you want to take this one?
Yeah, there's obviously been a lot of talk about vitamin C and what dose. I think there's something floating on social media about some doctor that's been giving vitamin C. The thing with vitamin C, I think there's definitely, so zinc and quercetin, if I'm pronouncing that properly, Quercetin is an anti-inflammatory supplement along with zinc. Zinc acts as an ionophore, basically to allow the uptake of hydroxychloroquine. I think quercetin has some sort of effect. I'm not sure the mechanism of action is not exactly sure about that right now, but it definitely has, it augments the effects of hydroxychloroquine. Now, with the terms with vitamin C, it's an oxidative it's an oxidative compound. So if there is some sort of or an antioxidant, sorry. So if there's any sort of oxidative process taking place, which might be associated, in my theory, which might be associated with the cytokine storm and some sort of oxidative reaction taking place, I believe that maybe vitamin C has an effect. The question is the dose, and that's up for debate. I don't see, I personally don't see any harm in taking a lot of vitamin C, but I don't know if you have any insight or input into that, Mike.
No, I mean, I want to say it's completely harmless, but the chances of someone developing toxicity, at least acutely from vitamin C, is essentially zero. The problem is when you take big doses over a long period of time, those people are very much at higher risk of getting calcium oxalate kidney stones. So again, if you take vitamin C in the short term, is it gonna be harmful? Within reason, that is. That's fine. So in terms of the harm, it's pretty minimal. But in terms of does it work, I think that's very much up for debate if there's even some benefit. But if there is some benefit, then might as well take it if it's only minimally harmful if you take huge doses over the long haul with the kidney stones. But again, I don't have any problems with vitamin C. I think it's, for the most part, it's harmless. In terms of does it work for sepsis, so there's actually a very small study that came out a little over a year ago where they gave patients with septic shock, they gave them a cocktail of, it wasn't just vitamin C, but it was also hydrocortisone, which is a steroid, and also they gave, what was it? It was another medication. I forgot what it was off the top of my head. But anyway, there's a very few, I think it was only like 40-something patients in that study, and they said, oh, maybe there's something to this because they had some good outcomes during that study. And then there's a subsequent study that came out over the last 4 or 5 months or so that did not show beneficial effect for the IV vitamin C. So, for sepsis, for septic shock, it's not something we give. As far as does it work for COVID-19, I haven't seen any studies that came out supporting that or refuting it. So I can't really comment too much on vitamin C other than to say that I don't know that it's effective.
Right, and you're going to hear this word a lot from physicians, and I know the general public will bang their head against the wall when they hear this, but a lot of the information that we are getting is anecdotal, and that's because we're just learning about this outbreak and the virus as we're going along. As we're learning with you guys too, so that's why. That's why we tend to throw this word anecdotal a lot, because we're talking to other physicians, we're reading different studies, and we're having to discuss and kind of learn and give advice on the fly. So we have to be really cautious what we're saying. I will add that, we've been getting a couple of questions on zinc and quercetin. From my understanding with what I've read about quercetin, there isn't too, I hope I'm pronouncing this properly. I've butchered medications like since the beginning of med school. But quercetin overdose is really rare. There doesn't seem to be any problems taking that on high doses. Zinc, again, mostly can cause a stomach upset. There's usually nausea, vomiting in terms of zinc overdose. You can have sometimes they say that you can have some changes in your taste, but usually it's going to be some GI issues that are with zinc overdose. So these are medications that, or supplements that are not going to do a lot of harm taking it, but if they have a benefit, right? I mean, I don't know how you feel about that, Mike.
There's some evidence that with this ACE2 inhibitor, it might be the enzyme might be related to metalloproteinase, which the zinc may or may not influence. But to give a broad recommendation in terms of will zinc affect the illness, don't know. I mean, there haven't been any studies. There's some reports of people who take zinc where they lose their sense of smell or taste, but overall, it's not really. I don't think that happens too frequently in the patients who take zinc. So I can't recommend yay or nay for that. Another question is with fever. So what about Tylenol versus ibuprofen or other NSAIDs such as naproxen or naproxen, Aleve? So the thing with the NSAIDs, though, that was based on some very small French studies that had some poor outcomes in patients who had the NSAIDs, the ibuprofen or whatnot. Now, I tend to never give ibuprofen or any NSAID in the intensive care unit in general, whether that's for someone who's very sick in the intensive care unit or maybe just a little bit sick or intubated. You have to realize when patients are in the intensive care unit, they either have or are at very high risk of having organ damage. Lots of times patients have kidney impairment where the kidneys are a little bit damaged and not working well. Same thing with their stomach, where the stress of the intensive care unit and the medications we give them put them at higher risk of having gastritis, which is inflammation of the lining of their stomach. Same thing with ulcers that could develop in the intestines and or the stomach. So also the ibuprofen can impact in a negative way the heart. So generally speaking, when someone's in the intensive care unit, we never give non-steroidal anti-inflammatory drugs, which is NSAIDs, such as ibuprofen, such as Aleve, such as naproxen. So not saying that we don't ever, but I really don't like to give it, and I rarely do give it. So the first line for fever, if we have to treat it, again, we don't always have to treat fever in the intensive care unit, but if we do, it's with Tylenol. Tylenol, it can be given through the mouth. If they can't get it through the mouth, it can be given rectally. And then it can also be given IV, which is very expensive, but we do sometimes give it to patients who can't get it any other way. So Tylenol is always the go-to. The really only downside to Tylenol is if someone has liver injury, liver dysfunction. So if someone has very bad liver cirrhosis or if they develop acute liver injury in the intensive care unit, we have to be extra careful about giving them Tylenol. So sometimes we do give the NSAID, the ibuprofen, but again, it's definitely not something I like giving and I rarely give.
So there's a question from Music Genius number 1. Any thoughts on why some younger people are seriously affected or dying related to viral load or genetics? So I'll jump on this. Just let me know what your thoughts are, Mike. So in terms of younger patients, one of the things we were initially told about this infection was that younger patients were low risk. The initial studies from Wuhan showed that probably after the age of 60, the risk was exponential or the mortality rate started to exponentially grow. I think somewhere after 80, the mortality rate was something like 24, 25%. So there was this false sense of security that if you are young, you were not susceptible to the infection. Now there's been some studies that have come out showing that, I think there was a study recently in Singapore that showed that pediatrics, children, even though they are asymptomatic carriers, their viral loads are really high, meaning that even though they're asymptomatic, they're shedding the virus more than adults, which is obviously a concern when you're talking about some of especially the schools in the Northeast, where there are much more. There's a lot of, I know there's a school out in Brooklyn that has about 6,000 students. There was a couple of outbreaks in this Brooklyn school. So you can just imagine these children are just walking around shedding the virus left and right. Now, One of the theories that's been discussed about why younger patients are succumbing to COVID-19 is the issue about the cytokine storm. It can affect anyone of any age. And again, why certain people are more susceptible to the cytokine storm or the overactive immune system, we really don't know. And as I talked about earlier in our live Q&A, there might be a genetic component, but we really don't know. So some of the reports coming out on the younger patients succumbing to the disease is the cytokine storm. And one of the things these cytokines are doing is they're attacking the lung parenchyma. And there is some theory that the cytokines are the reason that on path reports you're seeing this bilateral interstitial pneumonia. So some physicians and scientists think that the causative or the etiology behind this is the cytokines. And that's why younger patients are being affected now.
Now, someone was asking about cleaning vegetables. It's a tough question. On one hand, people are touching the vegetables at the grocery store, and then they put them back. And so if you pick up that one, in theory, you could get the virus that way onto your hands. And if you don't wash your hands and you touch your face, either your lips or your nose or your eyes, that is a possible transmission. So in terms of should you wash them, my recommendation would be to at least rinse them. I wouldn't put soap on them. I wouldn't go that far, but maybe you want to wait a little while after you first buy them before you eat them, or maybe you first rinse them off, then wait a little while. I don't know, 24 hours. I don't have a concrete answer for you. I'm sorry, but that's what I would do. That's what I would recommend.
So yeah. I'll just jump in and just add to what Dr. Hansen was saying. So the most food specialists, their recommendation when it comes to food and vegetables is just to wash your food and vegetables with water, and then not to use any soaps. And the reason why is most food experts believe that the soaps and the dishwashing detergents can get absorbed into the fruit and vegetables and cause some GI problems. Now, with that being said, even though they have those recommendations, there have been quite a lot of people tell me that they're using soap and water to wash their vegetables and fruits. We are in a very different situation than before in this pandemic, so I do understand people using soap to wash their vegetables and fruit. And as Dr. Hansen said, there is no clear-cut answer. But if you are going to use a soap, use a mild soap or mild detergent, and wash that soap as thoroughly as possible, to rinse it out, make sure you've gotten all that soap out and all the soap suds. I think most food experts are more concerned about the GI symptoms from the soap, but I think most of you guys are more concerned about the COVID-19 issue. So I would probably say that's much more higher on the concern list than having a little stomach upset from soap. But I don't know, just let me know what your thoughts are, Mike, on how you feel about that.
Yeah, I definitely wouldn't do soap just because soap could be, I guess the soap, there's probably a higher risk of having, illness from drinking soap or getting that into your intestines. It's probably still very low, but I don't want soap on the food that I eat. So, I'm not doing a lot of cooking, so I haven't personally experienced this very much, but in terms of recommendations, someone was mentioning frozen. That's one way to go. The other thing is soaking it or just rinsing off really good and waiting for a little while before you eat it. Does the cold kill it? Probably not, because we know that the virus lives in cold weather. So putting it in your fridge, that by itself is not going to kill it. But if you do rinse it and then wait a little while before you eat it, maybe a day or two or something like that, I think your chances are better off. But it's not a well-known of transmission, so it's hard to really comment, and there aren't any studies on this one way or another, at least not that I know of. So it's really hard to answer your question. Sorry, I can't give you a better answer. All right, so another question is about hydroxychloroquine, 400 milligrams. What are the risks of side effects with that? Oh, for if you take it for 5 days. Well, taking 400 milligrams of hydroxychloroquine for 5 days by itself is very, very safe. The risk of something bad happening at that dosage for only 5 days is very minimal. The biggest concern with hydroxychloroquine is when you give it someone long term. Okay, there are thousands of patients in this country who have lupus and or rheumatoid arthritis or mixed connective tissue disease who take Plaquenil, which is hydroxychloroquine, and they are just fine. The biggest concern in these patients who take it long term is the potential for retinal damage, and that's why these patients have to have annual eye screenings to check for retinal damage. And most of these patients don't ever have retinal damage. If they do, it's caught early so that the drug can be stopped or at least reduced in dose, but that's really the main concern. This whole concern about QTc prolongation causing arrhythmias with hydroxychloroquine, it's really overblown because by itself, the percentage of someone having an arrhythmia based on hydroxychloroquine alone, based on that dose, is very small. And it's going to be even smaller if someone only takes it for 5 days. So generally, very, very safe drug by itself. The problem is when you get into adding it to other drugs, and this goes for drugs in general, lots of drugs cause QTc prolongation on the EKG. So when these drugs are causing the QTc prolongation, when you start adding them, all these drugs in the same patient, the risk of having QTc prolongation goes up, and therefore the risk of arrhythmias goes up as well.
Yeah, and I agree 100% with what Dr. Hansen just said. And this is why we don't advise anyone taking hydroxychloroquine prophylactically or without physicians overseeing that, because there could be what we call drug-to-drug interaction. There could also be, sometimes you might be taking some supplements that might be interacting with the metabolism of hydroxychloroquine or chloroquine if you're taking chloroquine, and can potentiate those side effects, which are pretty low, but can be augmented or worsened. So it's really important that this medication is not something that people are taking without a physician's supervision, so that they can review what other medications you're taking and other supplements that you're taking, so that you don't have some adverse reaction to it.
Yep, and then someone was asking about what can they do to protect their lungs or get their lungs stronger in preparation for, possible COVID infection. The main thing is really just controlling whatever underlying lung problems you have, or any just medical conditions in general that you have, whether it's high blood pressure or diabetes or asthma or allergies or COPD, emphysema. You want to make sure all these medical conditions are controlled. And the way that you make sure that they're controlled is by visiting with your own physician, and then having, it's probably going to be through telemedicine on a phone call or like FaceTime kind of app. But visiting with your physician and making sure that your symptoms are controlled, your disease is controlled, and they might have to make medication adjustments and so forth. So there's no specific breathing exercises that you can do. And in general, it's just good to practice, breathing techniques where you take slow, deep breaths. That's good for, stress reduction, that sort of thing, mindfulness, that sort of thing. And stress reduction is actually important to keep your immune system firing on all cylinders. So to keep your immune system firing on all cylinders, you want to get good sleep. So typically for most people, that's 8 hours of sleep per night, but not just number of hours, but good quality sleep. Besides sleep, you also want to eat healthy, getting back to vegetables. And you also want to exercise. So I know it's hard for a lot of people because the gyms are closed, but if you don't have a lot of people in your area, you can go for a run outside, or you could do some kind of workout in your home, hopefully. But it is important to try to get 20 minutes, 30 minutes of exercise per day. It doesn't have to be crazy intense, just doing something. And there's plenty of workouts that you can find online to do. So between eating healthy, exercising, getting good sleep, and stress reduction, whether that's breathing techniques or yoga, something like that, or mindfulness. The other thing too is not smoking cigarettes. People who smoke cigarettes are at higher risk of having worse outcomes with ARDS. The other thing too is alcohol. So actually, a bad prognosticator of ARDS is people who drink alcohol, especially if it's done over the long term. So, drinking alcohol here and there, that's fine. But in terms of when you drink on a consistent basis, you're at higher risk of having a worse outcome from ARDS. So I know a lot of people are turning to alcohol during these times where we're all quarantined and staying home, but just be careful that you're not doing it too much. Maybe here and there, a glass of wine or something, but not, 6 drinks a night.
FECE just asked a question, Mike, on the overall mortality rate is similar to flu. Will make us re-examine our nonchalant attitudes towards seasonal flu and flu shots. So I'll probably take a stab at this question. One of the things is this outbreak in virus is constantly changing. We're getting new information. Initially, some of the studies out of China, we were thinking, all right, the mortality rate's going to be a little bit less than the flu, and then it started to go up, and then we started getting different numbers. Now, the WHO, this was in a recent Lancet article, the WHO is suspecting the overall world mortality rate is going to be roughly about 5.4%, 5.4 to 5.7% mortality rate, which is considerably higher than the flu. The SARS virus from 2003 was something like around 9.3 to 10%, somewhere in that range, and the MERS was something in the 30% range. So the MERS, which was another coronavirus, had a higher mortality rate. So we're obviously going to get more information on this. Some of Dr. Fauci and a lot of other leading health specialists believe that coronavirus is going to be a seasonal thing. Now, keep in mind, coronavirus actually does exist. It affects us every year. We just happen to have a strain this year that is that's causing this outbreak. So it's not like a virus that just out of the blue just popped up. Well, the strain did, but we have seasonal coronavirus. We just never had it to this extent, and mostly we had been focusing
not the same coronavirus, different coronaviruses.
Right, different coronavirus. Right, exactly. That's my point. So it's not like, oh, there's this new virus called coronavirus. We get this every year. So I think, me personally, I think our attitudes are going to change because I think we all realize how I think this is affecting almost every single person on this earth. I don't think anyone is I don't want to say immune. I'm trying to look for the word. Sort of protected from this virus. So I think our attitudes are going to change.
All right, someone is asking, how is this pandemic going to end? And I don't have a crystal ball, but I'll say it's not going to go away anytime soon. The only true way, there's actually two true ways to stop the virus dead in its tracks. One, if everyone just froze in place for 14 days, which obviously is not practical and will never happen. But if, in theory, if everyone just stopped what they're doing and stood in place for 14 days, the virus would die off. Because the only way that this virus can survive is through people. And the only way it gets transmitted and carries on is through people. So if everyone just stopped in place, didn't move, the virus would go away after 14 days. Now, that's not going to happen. I get that. The other way that this virus can get shut down eventually is with vaccination, but it's going to take time. It takes time to develop the vaccine, and it takes time to see in the clinical trials if it is safe and effective. And typically, these things takes a few years to develop, but with this one, because it's a new type of vaccination that's being developed, it's expected to be available in about 18 months or so. And if it does prove, that's assuming everything goes smoothly. If everything goes smoothly and according to plan, they'll be ready in about 18 months. And so not only when that vaccination is ready at that time, but also if everyone has to get it. if only some people get it, it's not going to wipe out, eradicate the disease. That's why we have influenza every year, annually. We still have it, but there's a vaccination for it, but it still happens every year because the virus mutates and has different forms, takes on different strains. So, like smallpox, that was eradicated with a vaccination. That's the way that we're going to get rid of this disease in the future, not anytime soon, in the future. Now, with that said, we can do things as people to slow down this virus so that the numbers go way down, so that we're not having to live out of our houses, stay at our houses all the time, quarantine. The way that we do that is by doing the things that we've been doing, but we have to be patient. We can't just rush back to how things were before, because if we do that too soon, guess what's going to happen? Right now it's going to slowly start to go away, but if we take our foot off the gas too soon, it's going to come roaring right back like a raging fire. That's what's going to happen. So we have to make sure that we do it long enough to the point where there's less and less cases, and at that point, that's when we can start to take our foot off the gas. And hopefully that vaccine is ready in 18 months or whatever it is. Dr. Yo, you have input on that?
No, I was just reading someone's question about, I was just going to add, there's someone that asked about, and I think it ties into what you were saying. They were asking about, I think it's RockSucks37 has been posting this question about why is there a disparity of COVID-19 fatalities among minorities. Now, I think, so I'll just address this real quick because it kind of ties into what you were saying, Mike. You'll see a lot more diverse populations on the bigger cities in the United States. Now, of course, Dr. Hansen and I are in the United States. I'm at the East Coast and he's somewhere in the Midwest, but you tend to see more diverse populations. I mean, it's true. You're New York, you're Boston, you're Philadelphia's, and with a diverse population, people are living and the diverse populations that are living in these big cities, they are much more closer together. There's a higher risk for transmission. So if you're seeing some of the fatalities, I would suspect it's because of the close quarters of these big cities. And there's obviously public transportation, which most people in New York, Boston are relying on for their mode of getting to work or getting home or whatnot. Now, in terms of equipment and healthcare, I can't comment on that because I don't really have that information. But it really follows what Dr. Hansen was talking about, where it's still practicing those social distancing, wearing the mask and taking those necessary precautions until we have some sort of a definitive or a vaccine and some definitive treatment that works.
Yeah, and then someone was asking about, DNR code status. I'm glad someone brought this up because I think this topic often gets overlooked. Even before COVID-19 came about, this is something that most people don't talk about in advance, and it's so important to do this in advance. And that is the question if you ever need a ventilator, do you want to be a full code in the hospital? In other words, if you go to the hospital and the doctor's telling you you need a ventilator and they ask you if your heart were to stop, do you want us to do compressions on your chest and or give you electrical shocks to the chest in order to try to revive you? Do you want us to do that? And a lot of the times the patient in return says, well, that depends on my prognosis. And lots of times we are not able to give a specific prognosis. We're able to give kind of a general idea about our thoughts about the prognosis, but not something concrete, not something specific. So if someone says in advance, if they know what they want regarding their wishes, that's very helpful not only to the healthcare staff, but also to the patients, and also helpful to the patients' families, because lots of times the patients' families don't know what to do, and if they feel like if they make the wrong decision, they're going to have to live with that guilt. So it's better if people can address this ahead of time. And I'm not saying, with this pandemic, we have to be, I'm expecting, so many people to die that everyone needs to address this question right now. That's not what I'm saying, but it would be helpful to yourself, to your family, and to healthcare staff if you know your wishes in advance. So basically what DNI, DNR entails is DNI stands for do not intubate and DNR stands for do not resuscitate. So the breathing tube is when someone's heart stops, the breathing tube goes hand in hand with what we do in terms of ACLS and resuscitation. So when the heart stops, that means we put a breathing tube in and have them on a ventilator. And we also, if it requires it, we do compressions on the chest and electrical shocks to the chest in order to revive them. Now, what I can tell you is if someone gets to the point, especially with COVID-19, if it gets to the point where their heart stops because of COVID-19, the chances of them recovering from the CPR, they might recover temporarily or very briefly, but the chances of them recovering from that hospitalization is essentially zero. Let me repeat. If someone, I'm not talking about kids here, I'm talking about adults. If an adult patient who gets so sick from COVID-19 to the point where they have ARDS, where they can't breathe, and let's say they get a breathing tube, okay? Let's say they get the breathing tube at that point, and then they still have a cardiac arrest after they get the breathing tube, the chances of us being able to revive them at that point, it might be temporary, it might be brief, but they're not going to be recovering from that. So if people know this in advance, I think they're more likely to think about this and make an explanation or reason with themselves and with their family in terms of what they want for their wishes. So I think it's something that people should think about before they end up going to the hospital. And it doesn't have to be just COVID-19 related, it just could be in general, what they want for themselves. So again, I know a lot of that depends on what is the prognosis. And only, your doctor can give you the best possible answer for that in that situation. But at least think about that situation before it happens.
Mike, there's someone that asked a question about sort of oxygen levels, and I think there was also another question about ventilators. So I think we're getting some questions on sort of vent settings. You wanna tackle that?
Yeah. So what was the question about vent settings in terms of?
This was somewhere earlier. I guess maybe they were talking about ARDS and
okay.
if it was harmful putting people on a ventilator. There's been a lot of discussion, and some physicians have been talking about this in the news recently.
Oh, yes. So, okay.
So you want to address that, please?
All right, so a couple of things on ventilators. Now, I know I said in one of my videos that ventilators are not a cure, and that is true. That's not to imply that they don't help, okay? So ventilators are not a cure, they are a form of life support. So when someone can't breathe on their own and they require a ventilator, the ventilator is a form of hope that can support their lungs and their body to hope where we hope they can get through this illness. It's a form of life support. Now, if you look at all what the studies show, that about of the patients who require a ventilator with COVID-19 related to ARDS, the survival rate is about 14% or so. The average length of time on a ventilator for COVID-19 ARDS is about 17 to 20 days. So the point being is that ventilators, they can save lives, but it's not a guarantee that the ventilator is going to save someone's life if they have COVID-19 ARDS. Certainly not a guarantee. Far from it. And that also relates to ECMO as well, and that's something we talked about earlier. In terms of ventilator settings, there's a study that came out of Italy based on the lungs being more compliant than expected for ARDS. Now, this isn't all COVID-19 patients with ARDS. This is based on a certain population of patients in Italy who had more compliant lungs than expected for ARDS. This was done by Dr. Gadoloni, something like that. Now, although there are reports of more compliant lungs than expected, first of all, for those of you who don't know what compliant lungs are, think of when you blow up a balloon. The hardest part of blowing up the balloon is the first part and the very end of when it's already blown up. That middle part is the easiest, okay? What that's referring to is the stiffness of the balloon. So when we're talking about compliance of the lungs, what we're really talking about is stiffness of the lungs. The more fluid and inflammation you have within your lungs, the more stiff the lungs become. And that's what happens with ARDS. Now, what these doctors in Italy noted on these patients is that they had less compliant lungs than expected. So that is making some doctors, intensive care doctors, think maybe we should change the way that we're managing ventilators, because in terms of ARDS, because typically what we do for ARDS is we have very high PEEP levels and we do very low lung tidal volumes for these patients. So there's thought that maybe we shouldn't be doing such high PEEP levels based on these more compliant lungs. We could actually be doing more damage than good. So again, this is a very small number of patients that they looked at. It's not all patients with COVID-19 ARDS. So it's too early to jump to a conclusion one way or another. But what we do know is that you're going to have to make your decisions on a case-by-case basis. So for each patient that you have, the general recommendation would be to use a low tidal volume and also use your own judgment in terms of how much PEEP to use. And of course, use as little supplemental oxygen as you can, because there is a risk of oxygen toxicity with patients in general who are on a ventilator. So that's the best I can do to answer that.
Yeah, I will say no. I agree. I agree, Mike. And sort of from an operating room perspective, when I have emergency cases and I have someone with ARDS, we're going to usually go low tidal volumes. And I don't know what settings you use in your use in the ICU, Mike, on your patients with ARDS. I tend to use 6 to 8 milliliters per kg.
The recommendation is 4 to 8 cc's per kg of predicted body weight. So most people go with 6. That's in the middle. So when you do that, the average woman based on that is going to be high 300 tidal volume, which is 0.3 of a liter essentially, or maybe slightly more. And then for the average male, that ends up to be around 400, 440, 450 cc's, which is a little bit less than half of a liter. So that's just the average. Yeah.
Yeah, that's usually my settings. And I mean, the thing with what happens on these ventilators is when you start increasing. See, there's 2 different settings. You can do volume control and you can do pressure control. In ICUs, you can do sort of a combination of it. But sort of the basis behind it is you want to set a tidal volume so that you can adequately oxygenate and ventilate the patient. And just think about, there's an equation that looks at pressure and volume. So when you set a certain amount of pressure, you're going to have if you set a certain amount of volume, there is a pressure that's going to be associated with it. Now, the other setting you can do is you can actually set the pressure that you want, but and then you will get a different volume. So you're controlling the pressure, but you're not controlling the volume. So if you have someone, let's say, with ARDS, and let's say I give a tidal volume of 300, the pressure might be, let's say, because there's a lot of fluid in the lungs, it's basically creating so much pressure. That pressure might be, let's say, 50 or 60 or 70. The higher the pressure is, and usually the textbooks will say something like 40 is like this cutoff, and anything above that, you start increasing your risk of actually injuring your lungs. And some of the textbooks will use this term barotrauma, where that can actually worsen the ARDS because you're causing a traumatic, you're causing some inflammation and trauma there. So now you're causing more of those inflammatory markers to come in. So we obviously, it's very difficult managing patients with ARDS because there's so many different factors. We obviously need to oxygenate and ventilate them, but we're also looking at pressures. There's something called peak pressures that we're looking at, plateau pressures, and so many different things that we're looking at in managing these patients. And I agree with oxygen from an operating room perspective. If we had a COVID patient that had ARDS, they had an emergency. Let's say they had a bowel, gangrenous bowel or something going on, and they had to come to the OR. I would probably run them at 100% oxygen because I'm not thinking about oxygen toxicity for a couple of hour case. But when you're in an ICU setting, oxygen toxicity is something, as Dr. Hansen mentioned, is something that we have to take into consideration.
Yeah, I see a couple of questions about CPAP. Yeah, I mean, sometimes we try CPAP. The concern with CPAP, which stands for continuous positive airway pressure, which is the mask that you put over, the concern was that it's aerosolizing, generating, so you're putting more and more potential virus in the air. And there's always a question of what happens to these patients who are placed on either CPAP or BiPAP. What are their outcomes? Because they looked at this for ARDS patients using BiPAP on these patients, and they had worse outcomes based on the studies. So that was based on ARDS patients in general. Those studies weren't specific to ARDS with COVID-19. So we don't know for sure because there aren't studies that are specific to that. A lot of us intensivists are debating with ourselves in terms of what is the best approach. Should we intubate sooner rather than later as a more precautionary, sooner rather than later? Or should we be more reactive where the patient's crashing and then at that point we intubate? So it's not a clear-cut path moving forward, and we're really having to wait for these studies to come out to see what is the best path to go down.
And Mike, there was also a question about someone. I guess it's someone asked, Kyle McGinnis asked, is it true you can use settings on a vent to sedate a patient without anesthetic? No. Basically, you can intubate someone and keep them on a vent without sedation. But if I'm using the ICU ventilators don't have vaporizing gases like the operating room ventilators. So into critical care doctors will use IV sedation. A lot of times it's usually a Versed or midazolam, which is a benzodiazepine fentanyl drip, or one or the other, or propofol. I don't know what you use. Probably use both of them, right, Mike?
Yeah, typically either fentanyl or propofol. Yeah. All right. I know. Let's see. Someone's asking, will I survive if I get COVID-19? I hope so. I hope I don't get it. I hope I don't get it. I hope I survive. No way to know. There's no way to know. If I do have asthma. If that's what you're getting at, I have asthma, and it's very mild, intermittent, and so therefore it'd be considered controlled asthma. So would I be? That kind of gets back to what we were talking about earlier, controlled versus uncontrolled disease, specifically asthma. Because my asthma is controlled, I would probably be better off than someone compared to uncontrolled asthma. But again, that's just based on my opinion. We don't have any studies to prove or disprove that, and that's kind of where we're at with that.
Mike, we just got this question from Amber Jonathan Forever. She asked the question of SpO2 percentage to go to the hospital. A couple of people have asked that question now, so you want to address. She said 94, 9. I guess I think some people they have some home pulse ox, so they might be testing it at home and using that as a marker. You want to give us your thoughts on that, Mike?
Yeah, so that's a great question, and with most great questions, they're hard to answer. So this is a question about if you have the pulse ox on your finger at home and you're measuring it, at what point do you need to come to the hospital? It's always going to be on a case-by-case basis. So you want to, if someone were to call me and ask me, do I need to go to the hospital? It's not only going to depend on that number, but also what their symptoms are. So are they feeling short of breath? Because some people have low numbers without feeling short of breath. Are they in respiratory distress? How fast are they breathing per minute? So if you count your number of breaths per minute, that's going to also factor into my determination if you should go to the hospital or not. Are you using all the muscles of breathing? Are you in a lot of distress in that way? If you're having shortness of breath, if you're in respiratory distress, if you're breathing fast, you should go to the hospital regardless of what that number is. The question is a little hard to answer if you feel completely fine and that number is lower. Then it's a little bit more difficult to answer. But the ultimately it's going to be up to the physician that you speak with on the phone about should you go to the hospital or not. And if you're in doubt, just go. If you're in doubt about it, just go. Generally speaking, again, some people, the other thing you have to look at is some people have chronically lower oxygen levels. So if you're someone who normally has an oxygen of 100%, and then all of a sudden now you're reading at 90%, that to me is more concerning than someone who is always low at, say, 92%, 91%, and now they're having SATs 89%. So again, there's lots of different factors that have to be taken into consideration, and it's always going to be on a case-by-case basis. So my recommendation would be to call your physician to get that sorted out for you. If you're not able to call or you're just in doubt, then just go to the ER and go from there.
Yeah, and I'll just follow up to what Dr. Hansen just said. Well, one of the things as clinicians we are taught from first day of medical school is not to chase numbers and actually to look at the patient and look at their symptoms. Sometimes equipment, as an anesthesiologist, I can attest to this very personally. I've had equipment failure in the middle of a surgery, where my all my monitors go down or the electricity went down, and you're really, really terrified. You're like, what do I do? Again, you look at your patient, you look at your symptoms, you look at the patient's breathing and whatnot, and it's the same thing here. If you're not feeling well, you're having difficulty breathing, as Dr. Hansen said, but your pulse ox is at 100. I mean, you could have a pulse ox at 100 and having some underlying etiology. Something else that Dr. Hansen mentioned, he mentioned earlier about methemoglobinemia. If you have carbon monoxide poisoning, your pulse ox will still read 100%. So, but you've been exposed to carbon monoxide, and the reason why is how the pulse ox works. And I won't get into the nerdy physics behind it, but it's just how the pulse ox is detecting. It detects hemoglobin and deoxyhemoglobin and hemoglobin. And if you look at the back of a pulse ox, there's a red light. It's an infrared light that shines, that penetrates your skin, and it sends a signal back into it's like a detector on that pulse ox. So if you have carbon monoxide, the pulse ox actually thinks the carbon monoxide is oxygenated hemoglobin. So it throws off the number and gives you 100%. So I was just using that as an example, how a number, if you're just going by numbers and not signs and symptoms, and also like getting a history on someone, how that can be disastrous.
Yeah, so the bottom line is it's always a case-by-case basis, and if you can't get the phone call to your physician, or if you have any doubt, just go to the ER. So, all right. And what else do we have here? You seeing anything, Dr. Yo, for questions?
There is a question to someone just asked about, doesn't hyperventilation cause a higher SpO2 as well? Princess T 1979. You want to?
Yeah. So yeah, absolutely. Hypoventilation can cause a decrease in oxygen levels. That's what we see with patients who have COPD exacerbations, meaning emphysema, where they get worse with their emphysema. They have high carbon dioxide levels, meaning high CO2, and as a result, their oxygen levels drop. So that's one example. Another example of that is what happens when someone overdoses with certain medications, when these medications make them sleepy to the point where it decreases their respiratory drive, they end up retaining carbon dioxide levels in their body. And what happens is the carbon dioxide levels increase in their alveoli. So if you think of the alveoli like a sac, all right, when they start to increase their carbon dioxide levels there because they're not breathing it out, what happens is there's less room for oxygen in that air sac. And so that's why oxygen levels go down when the CO2 goes too high.
So someone has the question, is this why they use arterial tests in hospital, so a real reading of stats and not rely solely on equipment? I would say yes, you're correct. Music genius number one. That we use the ABG as a marker. Now, your pulse ox is going to give you a lot of good information. Dr. Hansen mentioned earlier about methemoglobinemia. sort of the textbook and textbook or on our boards, the question we get is about methemoglobinemia. And you have a patient that has methemoglobinemia, and their pulse ox reading will be 85%. I'm sure you probably have come across that in your boards, Mike.
Not only in boards, but in real life. It's like textbook 85 to 87%.
Yeah, I've actually had that once before, where I gave a patient. I'm losing my train of thought. The anesthetic spray.
Bupivacaine.
No, bupivacaine. I'm losing my train of thought. I have to look this up. But there's an anesthetic spray that causes methemoglobinemia.
Oh, lidocaine can do it too. The canes.
One of the canes. I've been so focused on COVID right now, I can't remember my local anesthetics. Okay. Anyways, I did have a patient that I did it's the hurricane spray.
Yeah,
hurricane spray.
Benzocaine.
Yeah, benzocaine, exactly. So actually, I did have a patient with that. So it seems like you had the same thing with that. So the point is that you have to look at your monitors, you have to look at your labs, and we do use an ABG. And it's not to discount the pulse ox, but again, like I said, you have to use clinical correlation and not go chasing after numbers.
Yeah. All right, someone's asking me, what do I take for my asthma? I have albuterol inhaler. Albuterol is the same thing as Ventolin or ProAir. I typically only take it either if I know I'm going to exercise in the cold weather, I'll take it prophylactically, so I'll take it before I go running. Or if it's triggered by something like working out or laughing too hard in the cold weather, basically the cold and the exercise, especially in combination, that's what triggers my asthma, and that's when I need it the most. But I don't take it on a routine basis. I don't take it regularly. Are these rescue inhalers safe to be COVID-19? So the rescue inhalers, they are kind of like a temporary assist, if you will. And it's not specific to any disease. It could be wheezing, meaning bronchospasm, that is caused by either asthma or COPD, meaning emphysema, or other medical conditions that could cause wheezing. So what the albuterol does, which is the Ventolin or the ProAir, what that does is it temporarily gets to the airways, and the smooth muscle that lines the airways, it relaxes that smooth muscle, and that's what causes the airways to dilate, to get bigger and relax. And that's what opens up the airways and improves the flow when you breathe. So these medications, they act quickly, but they also only act for maybe a couple hours at best. So it's just a temporary assist, if you will. It doesn't fix anything, doesn't fix any underlying illness. It just helps with the breathing for a little bit, and that's about it.
There's a real good question, Mike. Someone just asked this question about, it was hydroxychloroquine. Okay, has there been any look into people that have lupus or arthritis that are already taking the medicine hydroxychloroquine? Are they not becoming infected?
Well, that's a great question, and that's something I'm very curious about myself. Unfortunately, we don't have any studies as of right now to say if that's true or not, if they get less infections compared to other people, or if they do get infection, do they have less severe illness compared to others who don't take these medications? So yeah, it's a great question. It's something I'm very curious about. And I'm also very curious about for the people who are taking these ACE inhibitors and angiotensin receptor blockers, these ARBs. I'm especially interested in the ones who are taking Losartan and Telmisartan, because these are the ones that I think are going to end up having the most promises, the most promising results. The other thing is that I don't know if this is true or not, but I know a lot of people who are on these Telmisartan, Losartan, these types of ARB medications, and they seem to get less colds. And less, so colds, there's actually now 6 different types of coronaviruses that can infect the lungs. 5 of them is the common cold. The 6th one is this new virus, SARS coronavirus 2. So I wonder, because these coronaviruses that cause, just a common cold, the ones who are getting less colds who are on these medications, I wonder if that's a specific reason why, if that is true. So I'm very anxious for these new studies to come out where this Losartan is in a clinical trial, and I want to see the result of this as fast as possible. And then I wish they do a study, they probably will, on patients who are already taking these ARB medications for other reasons, for diabetic nephropathy, for congestive heart failure, for hypertension, high blood pressure. For these patients who are already on these medications, do they have, this would be a retrospective study, do they have less upper respiratory infections, less incidence of COVID-19 compared to the general population? And if they do have, for the ones who do get COVID-19, do they have less severe illness compared to the people who aren't on these ARB medications?
Mike, that was a good question from Kyle McGinnis. How do you know when a COVID patient is ready for a med-surg step-down unit? You wanna tackle that since you're in the ICU a lot?
Yeah, it's a tough question. We always gauge it on a case-by-case basis. So one of the things that we're looking at is which way is the patient trending? Are they getting better? Are they staying the same? Or are they getting worse? So if they look like they're trending in the wrong direction, that's the reason why we bring them to the ICU, and hopefully they don't get worse. But we see what happens, and if they do get worse, then we have to undergo more aggressive measures like intubation, ventilator, and so forth. If they are in the intensive care unit and they're trending in the right direction, and we see that they're stable, we like to see that they're stable typically 24 hours before we make that decision to move them to another part of the hospital. So the answer is it's always on a case-by-case basis, but as long as they're not trending in the wrong direction and they look like they look like they are stable, typically for 24 hours, that's what we like to see. That's when we feel more comfortable about sending them out of the intensive care unit to the other part of the hospital. Oh, another thing I want to say about the previous question is please don't run and jump to trying to get these new medications that aren't proven to work. This is all things that I think or I feel good about, but doesn't necessarily it's going to work. And the wrong thing to do would be to go out and try to get these medications in the chance that they will be better for you. The recommendation is if you're on these medications, continue to take them and continue to control whatever medical problems you have. But don't run out and get these medications in anticipation of you getting COVID-19 or for someone else.
Right. And again, like we talked about earlier, a lot of these, any medication that you're taking, they have drug-to-drug side effects. So you are able to get it. I advise you not to take it unless there's a physician's supervision. The other thing, too, is a lot of these medications you probably cannot even get. I think the only one is hydroxychloroquine. I've been getting some questions on my channel about remdesivir. Remdesivir comes in an IV format. Gilead Sciences, which owns the patent, I think they released 1.5 million doses to physicians and hospitals and for anyone doing any experimental studies. So it's not like you can a doctor can give you a script or you can just run down to CVS or Walgreens and get remdesivir. But I believe that hydroxychloroquine, because it's been around and it's been used to treat inflammatory arthritis and lupus, it's something that you can get a script for. But again, something I think we're not advising is to take it prophylactically. And if you do have symptoms and you do come down with a COVID infection, to first discuss with your physician, with your primary doctor, or with the emergency room doctors, because they will have all that information that they need to determine what's your dose, how long you should take it, and even if you should take it in the first place.
Yeah, I know someone was asking about they take hydroxychloroquine and prednisone. Are they at increased risk? It's really hard to say. We just don't know. On one hand, it might be beneficial. On one hand, it might be hurting you. Hydroxychloroquine, we're still waiting on the clinical trials. And with respect to the steroids, we just don't know if it's actually hurting people or potentially even helping people. In general, when someone is immunosuppressed with either serious medical disease that impairs their immune system, or if they're on medications such as chemotherapy or medication that suppress the immune system, in general, when someone's immunosuppressed, they are more prone to getting infections and more prone to getting worse infections, more severe infections. But with this specific case, we can't always apply that to this specific case of COVID-19 because we just don't know. There's a possibility that hydroxychloroquine can reduce your chances, and even the same thing with steroids, or it can make it worse. The answer is we just have to wait for the clinical trials of hydroxychloroquine. And as far as the prednisone, it's just we don't know at this point.
What other questions do we have? So there was Mike, since you're a pulmonologist, you can answer this question. Someone had something about the BCG vaccine, which I believe is used in a lot of the developing nations for tuberculosis, which we don't do it in the United States, and I believe in most Western nations. Someone said, what is the risk of BCG and the risk of COVID?
Well, BCG, if anything, it might help reduce the chances of getting tuberculosis. But again, we don't give that in this country. So in terms of BCG and tuberculosis, it might help prevent it. But in terms of COVID-19, it's not going to have any impact because, for one, we know that this is a virus and not a atypical bacteria, which tuberculosis is. Even though some drugs do have, some kind of impact on other kinds of illnesses. For example, azithromycin is an antibiotic, and that actually helps some people with upper respiratory infections that are due to viruses, not necessarily bacteria. So even though it's not a golden rule to say that, something that's bacterial might not necessarily help with something that's viral, the BCG vaccination is meant to reduce the chances of getting tuberculosis, which is a bacterial infection. So that's a vaccination, not a medication. And I don't see in any possible way how that would help either prevent or reduce the severity of COVID-19.
And I will also say, I remember now when I was born in England, and I got the BCG vaccination. So I've done a little research into this. BCG actually over about a 10 to 12 year period will start to decrease in terms of being picked up by a PPD. So someone that was a child that had the BCG vaccination, probably by the time they are in their late teens or in their sort of young adult age, the BCG should have no effect on the PPD. So if you are testing positive with the PPD, you most likely were exposed to tuberculosis. So just to throw that out there, because that's coming from personal experience.
Yeah. And then let's see. Any other questions you see?
Let's see. So someone just said about RBCs have ACE receptors. Stands to reason that virus would bind the cells even though they not gain a benefit from invading RBCs, no nucleus.
Actually, the red blood cells don't have ACE2 receptors. However, the virus doesn't. No, it definitely would not penetrate red blood cells. Oh, do you see any other questions, Dr. Yo?
Let's see. Someone said, Rebecca Mount Nieto just said, stay inside. Do you need masks or gloves? The new CDC recommendations, which I personally feel were a little too late, is to wear masks when going outside. Me personally, if you have seen my YouTube channel, you know I've got a big old tactical gas mask that I'm wearing to work. But when I'm outside, I'm just wearing I think I have it somewhere here. It's just a mask I wear when I'm going outside to the supermarket, and when I'm going out running. So definitely wear a mask. Now, in terms of gloves, I think this is something I go back and forth with. I personally don't see in the general community, because remember, if you're practicing good hand washing and good hand hygiene, then I don't really see why you would need gloves, especially if you're wearing a mask. Because if you're wearing gloves, and let's say I'm touching all sorts of fomites, or I'm touching contaminated surfaces, and I put that on my face, I'm still going to be exposed. So for me, it is hand washing and masks are the two more important things than wearing gloves. But I don't know how you feel about that, Mike.
Yeah. So the thing with the masks, and we really look to South Korea and Hong Kong and Singapore and Japan. They really, and even in Wuhan, what they did was they did a lot of things. But one of the things they did was they were experienced from both the SARS and the MERS outbreak. So they were way ahead of us in terms of how to handle the situation, where the people were wearing masks, where the people were hand washing, where the people were not touching their face, where the people were social distancing. So that was one of the things that they did well, and one of the reasons why they had reduced numbers of infections. The other thing they did was from a more global social aspect, and that was they they tested. They were ready with these tests, and they tested pretty much as many people as they could right away, and that in itself made a big difference, because when you test right away, then you can identify who has it, who doesn't, and then whoever does have it, you quarantine them for 14 days. Whoever doesn't have it, you don't have to do that. They also shut down a lot of public places right away, so they did all these measures, all these things that had a big impact onto why the numbers were so low. Now, when you look at there's a study that was done in the what was it annuals of internal medicine. They looked at a study in Singapore where they didn't know the patient was infected with COVID-19 initially, and so this patient exposed 40 healthcare workers, and none of the healthcare, they actually did a bronchoscopy procedure too. That was the only time where someone wore like an N95, but other than that, it might have actually been a surgical mask. But essentially, all the healthcare workers who were exposed, the one thing that they all had in common was that they all wore surgical masks, and there was zero infections in these healthcare workers. So that just goes to show the importance of the surgical masks and how the respiratory droplets are prevented from being spread from one person to another if they have that mask on. So, unfortunately, we didn't have. There's a couple of things. First, we didn't implement masks for everyone right away when this outbreak was happening. And the other thing is there's not enough masks. So if there's not enough masks, the priorities have to be the healthcare workers, the people who are in the hospitals. That's where the priority has to be. So if you have to ration the masks, they have to go there first, and then public second. Unfortunately, the CDC didn't take the cue from what happened in Singapore and Japan and Hong Kong and South Korea, and what they did right with the masks. Because if we had enough masks in this country, and if people were wearing them sooner rather than later, there's no question that would have reduced the numbers. Now, we should have also been doing other things to reduce the numbers, but that's definitely one of the things.
All right. I think we've been on for about over 2 hours now.
Yeah.
We initially wanted to do this for about 60 minutes, but these questions are great. We love talking. It's making both Dr. Hansen and I go back to our medical school textbooks and just look at the basics, and then try to apply that to this COVID outbreak. We're enjoying the videos, and I'm loving the questions. It's really making me think. Dr. Hansen and I, we're thinking about making this into a weekly live show. We were thinking we would just, If this is something you guys like, we will continue doing this. So if this is something you guys want, just let me and Dr. Hansen know. We'll try to do this once a week. Take questions. I know Dr. Hansen's got his Instagram page. You guys can also follow me on my Instagram page at ECA Wellness, and my YouTube channel is Dr. Yo. It's just like my screen name here. You can find my YouTube channel and all the videos that I'm posting. Dr. Hansen and I, we sort of keep in, we went to medical school together. He was my med school roommate, so we've known each other for about 17 years now. One of these days we'll tell you the story of how we met. So we'll because of our clinical practice, we will probably have to do this like once a week, and also the videos that we're posting. So it seems like you guys are loving this. So we'll try to do this next week. And if you guys have any questions in the meantime, you can hit up Dr. Hansen on his Instagram page or his YouTube page. You can hit me up on my
Hey, type in your Instagram, because people are asking for yours.
Oh. Yeah. Okay, so here's my. I run a wellness company, a wellness and health company in Rhode Island. I'm the medical director. And then if you look up Dr. Yo on YouTube, you should be able to. I'll just do a search on Dr. Yo, and you should be able to find me. So you can ask me any questions. Instagram is actually a little bit better. I get a lot of questions on YouTube. I try my best to answer all of them, and I'm sorry if I can't. But if you guys have any questions, just find me on Instagram, or you can also message me on YouTube.
By the way, I had fun doing this, both with Dr. Yo and with you guys. Thanks for coming here and asking questions and commenting. I look forward to doing it again. As long as there's a lot of yeses, I'll go and read those comments. But what do you say we do this in a week from now, Dr. Yo?
Yeah, let's definitely do that. So guys, we'll put a post up and just have schedule a time. And thank you, everyone. We're sorry we couldn't answer all the questions. We're trying our best here. But if you guys, Mike, you want to post your Instagram page too? Someone just Jennifer just asked you for.
I actually don't know for sure what it is. Maybe if someone knows, can they?
I have your Instagram.
Okay.
We're Instagram friends, so let me pull it up.
I should go on there more than I do. I've just been so busy with everything.
Okay, so here, let me type up Dr. This is Mike's Instagram. I'm typing it up now. Dr. Hansen. There we go. Oh, let me just do the @ Dr. Hansen.
Yep. Jennifer, Karen, Lisa, Mutated Genome. Thank you all. Much appreciated. And Kristen, there you are. And everyone else, thank you very much. And hit us up on either YouTube comments or Instagram. And we plan on doing this a week from now. We'll let you know when we do that. And listen, everyone, please stay safe. Just please do your part for everyone, for not only for yourself, but for everyone else. And thank you for taking the information that we say. We try to get you the most accurate information possible. And it's all based on, to the most part, as much as we can, based on evidence-based medicine. So we don't have all the answers. The literature doesn't have all the answers, but we're doing our best to either give you answers based on these studies or based on expert opinion from medical doctors. So thanks again. And Dr. Yo, you have any final thoughts?
No, Mutated Genome. We looked at the OBS software. We're trying to figure out what is the best way to do this. So it was something that actually came up. We're probably going to have to play around with it this week. This ECAM may not be working. So thank you so much, guys, for being patient with us. Dr. Hansen's got his phone right to his face. He looks like one of those ventriloquists, and looks like I'm a little puppet that you're talking next to. That's what it looks like on my screen. But thank you guys so much, and thanks for the patience with our audio-visual problems earlier.
Rachel, sorry, just mentioning names. Rachel, she's been asking a lot of questions, comments. Thank you. Jennifer.
Yep, Jennifer, Soldier of God 12. Thank you for all the comments. I try to answer all of you guys as much as possible when I'm at work. So Again, the ones that I'm so sorry that I can't answer, I'll get to you. Again, like you said, just send me those messages. I text and talk with Dr. Mike quite often, so we're both talking about things we're reading, and we're sharing that information with you guys. So,
yeah.
thanks so much, guys.
All right, take care. Bye now.
Have a good night. Thank you, guys.